Good day, everyone. My name is Justin DeToy. I'm one of the hematologists at Fitz-Donald Gordon. And I just want to say, or start by saying, this haploidentical project would not have been possible without the big giants, hematology giants in South Africa, like Jackie Thompson and David Britton. I mean, they established the first JC-accredited transplant unit in South Africa, but currently it's still the only unit in Africa that is JC accredited. Secondly, I would also just like to say thank you for Andrew McDonald and that's actually how this whole project started, is when we were on the way to one of these heme-onc conferences, and we had a discussion about our haploidentical transplants. And that's where the idea came, actually, that we should collect data from the private and public sector together and present it. Thirdly, I wanted to say thank you for Stelfa Berg. She enabled me to get the research ethics, and also gave me the REDCap tool to create a database in order to collect the haplo data. And then, of course, I wanted to say thank you to all the other hematologists that form part of this collaboration: Michael Cass and Cecile, Jenna, Prof. Matthew Siftel, and Vernon Lowe. So why is haploidentical so important? So we obviously know that we face more challenges to find donors in South Africa. Our local registry is not representative of the local population. In 2017, there was around 73,000 registered donors, but the majority of them were Caucasian. The potential donor pool is very restricted due to our high seroprevalence of HIV, around 13.1%, and the HLA alleles of people of African descent are genetically highly diverse. And then lastly, matched unrelated donor transplantation is very expensive, and therefore it's not often funded, even if you're on a medical aid, while only 17% of South Africans do have a medical aid. So haploidentical transplantation is an attractive solution. Now, just to come to this project, so it was a collaboration between Groote Schuur and Pretoria East Netcare. It was around 134 patients that we analyzed. All of them had high-risk hematological malignancies, 44.8% at AML MDS, followed by 16.4% with ALL, and then 38.8% mostly with high-risk lymphoma. The recipient median age was 44, predominantly males. Mostly they received myeloablative chemotherapy. The donor median age was around 36, predominantly male. 58% were sex-matched transplants, and 71% received peripheral blood stem cells as stem cell source, while 40% had developed acute graft versus host disease at day 100. When we look at the overall survival curves, the green is the lymphoma group, the blue is the AML MDS, and the red is the ALL group. Clearly the ALL group did inferior to the other groups, and this was significant. But apart from that, we could also prove that the AML MDS group, the survival was actually equivalent to what you would expect at international centers. Secondly, the cumulative incidence of non-relapse mortality at day 100 was 18%, which is acceptable. However, the 1 year and the 3 years was a little bit higher than expected, and the cumulative incidence of relapse was acceptable. If we looked at our multivariate regression analysis, older donor age was associated with inferior disease-free survival, while other diagnoses, or mostly lymphoma groups, were associated with a higher relapse incidence. And if we used peripheral blood stem cells and offspring donors, then it would lead to a lower relapse incidence. So in conclusion, this data supported the feasibility of haplotransplant and suggested that utilizing a younger parent or offspring donors are viable options for patients with acute leukemia and MDS who lack a suitable related or unrelated donor in sub-Saharan Africa. Finally, I just wanted to also say that or emphasize rather, that we must continue collaboration between public and private sectors. And also what I've learned is that setting up a database for retrospective data collection is challenging. I propose that we create a shared platform to collect data prospectively or even real-world evidence. In transplantation, quality management is imperative to enhance patient outcomes, and therefore data recording and to benchmark yourself is part of this process. And we can achieve this definitely by working together. And then finally, this will also enable us to set up a prospective studies or best case studies and pathways across our country or context. Just wanted to say thank you for the collaboration.